So this is basically the intro case. So this series is going to talk a little about MASLD and MASH, and there's going to be different lectures on it. So this is the basics. This is the first in this series of lectures. So we'll kind of get started just from the beginning. And you guys all know me. I'm Suzanne. I'm a nurse practitioner at the Washington, D.C. VA Medical Center here in Washington, D.C. Everybody's already registered. And then I'll leave this up for a second. So GAP is an organization that I'm part of. It's a GI and hepatology APP network. And there's a lot of educational information on MASLD and MASH and different things. So this QR code will kind of get you to that website, but I can also show you guys that website tomorrow at work. It's got a lot of good educational information. So we'll get started. So steatotic liver disease is what we're going to talk about. There's some new nomenclature, so they've adjusted some of the names that we historically had used to kind of define this disease. And we look at steatotic liver disease kind of as an umbrella term that covers all of these liver diseases that we see under it. The main one that we talk about and that we can see is MASLD. So it's metabolic dysfunction-associated steatotic liver disease. Used to be called NAFLD, non-alcoholic fatty liver disease. But a couple of years ago, there's a big group that met and decided to kind of adjust the names. And then under that, we see MASH. So it's metabolic dysfunction-associated steatotic liver or steatotic hepatitis. That's called MASH. And we'll go through kind of the differentiation between MASLD and MASH. So you have that. So that sits on the far left of the spectrum. And then we can move closer to the inside. Then you can have MASLD. So you can have someone with metabolic dysfunction-associated steatotic liver disease that also drinks alcohol. So you can see on this graph here, it talks about how much alcohol a person will take either every day, every week. And then you can say this could be someone who's MASLD with MetALD. So they have some component of metabolic dysfunction, but they also have a component of alcohol liver disease. And based on their alcohol intake, you can say whether it's MASLD predominant or alcohol liver disease predominant. Then we move on and we have just straight alcoholic liver disease. So it's someone who doesn't have any of those metabolic risk factors, but they have alcohol-related liver disease. And we'll see, if we biopsy that patient, we'll still see steatosis or fat on their liver biopsy. And then we have other kind of specific etiologies of steatotic liver disease. So there's DILI or drug-induced liver injury where someone could take a certain medication. It could be an herbal or a prescription medication and develop steatosis on liver biopsy. And then there's other kind of diseases that we kind of won't get into in this talk. Or there's cryptogenic. So they have fat seen on their liver biopsy, but we don't really have a cause for it. They don't drink alcohol. They don't have any metabolic associated liver disease. And again, that's won't be the super focus of the talk, but just knowing that these exist so we don't blame everything on MASLD. So how do we define it? So we can see steatosis. So we can see there on imaging. So I know most of you guys look at RCTs and ultrasounds that we get for our transplant patients, whether it's kidney or liver, and the radiologist will comment they see steatosis in their liver. So you have to see either on imaging or on biopsy. We don't do as much liver biopsies as we used to do because we have so many other kind of great non-invasive ways to test for steatosis or to test for fibrosis. But first you have to see steatosis. So either imaging or biopsy. And then you look at the patient's history. So do they have any metabolic criteria? And you can see on the right-hand side, there's both adult and pediatric. We'll kind of focus on adult because I mean that's the population we serve. If they have an elevated BMI, if they have an elevated fasting serum glucose or hemoglobin A1C above 5.7, or they're on treatment for diabetes. They have elevated blood pressure, or they're on blood pressure treatment, if they have elevated triglycerides, or they're on a statin, or if they have an elevated HDL. So really, that's if you think about our patient population that we see at the VA, almost everyone has one of these type of things. And you can probably extrapolate that to the entire American population. So we look at our here, do they have exhibit any metabolic criteria? If the answer is yes, then we look, is there any other causes of steatosis? So that's when you want to look and kind of do a good H&P and find out their alcohol intake. So is there concern that they have excess alcohol take. Is there a MASLD alcoholic liver disease overlap, which we see a lot of. If there isn't any alcohol, then we can say that's just straight MASLD. If there is alcohol, then we kind of have to add that into our diagnosis. On the other side of the spectrum, let's say they don't have any of these adult criteria, then you're looking for any of the other causes of steatosis. So, like we talked about, pure alcoholic liver disease, DILI, so drug-induced liver injury, or if there's nothing, we can call it cryptogenic cirrhosis. So they've kind of stratified and been able to kind of pick this nice blow mark so you can kind of look at where your patient fits in these criteria. So how does it affect your practice? Really, it's a lot about the terminology we're using. So instead of using NAFLD, we're using MASLD. Instead of NASH, we're using MASH. So you may still see the older nomenclature, like if someone, obviously if there were notes written before that time, or sometimes, it takes time for everyone to adapt changes in the names. But really, we can use most of the data that we have from the NAFLD population, and it'll fit for MASLD. So the ASLD, which is our liver, kind of our academic liver practice guidelines, they basically said that all the guidelines that we had for NAFLD, you can apply to patients with MASH and MASLD and MASH. So they really are basically the same patient population, but we're just using new names for them. Again, just kind of going more in detail. So to be kind of put in the MASLD category, you have to have hepatic steatosis. So you have to see fat either on imaging or on your liver biopsy. And then you need to have one of these criterias. And then you can't have someone who is kind of drinking alcohol more than 20 to 30 grams per day. So it's 20 grams for women and 30 grams for men. Men are allowed to drink a little bit more alcohol than women in these categories. So looking at these, I mean, these are pretty tight categories. This is the majority of the population is going to fit into one of these categories. So you have someone who has elevated LFTs. They come to your clinic, you get referred, you want to see, hey, what do I have to do for this person? A very easy kind of score you can use is get a FIB-4. So it's basically a calculation using the age of the patient, the AST, and ALT, and you can really, and the platelet count, and you can give you a score, and they can use that score to determine if this patient's at risk for having advanced fibrosis. So when you look at kind of when we're evaluating patients and they have elevated LFTs and they get sent to the hepatology clinic, this is one of the things that we look for right away to kind of risk stratify these patients. So you can see here, if they have a low FIB-4 count, then you can just reassess it every 1 to 2 years. If they have diabetes, if they don't have diabetes, then you can do it every 2 to 3 years. So it's something simple that, primary care can do to kind of watch these patients. Now, let's say they have an elevated FIB-4 count, so above 1.3. Then you're going to move to other testing. So we have VCTE, which is basically the FibroScan, which we have available at the VA. So it's non-invasive way to measure fibrosis and steatosis. So we can send them over to Craig. He can do a FibroScan and give us a number too. So if that number is low, we can also do an ELF score, which is another serum biomarker that we have available at the VA that we send out. So if we have those two tests, and your FIB-4, those two tests are low, then we can say this patient's at low risk. They may have steatosis, but do they have MASH? Are they going to develop into something more worrisome? And then on the bottom in the red box, you see, okay, now we have a FIB-4, but we have an elevated ELF score and their FibroScan is showing more concerning. So what do we do in that case? So in that case, those are the patients that we really want to come to the hepatology clinic. These are the patients that may be at risk for developing MASH, so they're at risk for developing that steatohepatitis, that inflammation, or even cirrhosis. So these are the patients that we want to see in hepatology. Those are the patients that we worry could progress to needing, all the complications that come with cirrhosis, HCC, and possibly needing transplant. And then you can see at the bottom here, there's kind of another caveat where if you have someone with a very elevated FIB4, you can just send them right over to hepatology, and they're really going to be the ones that we need our hepatologists to evaluate and to make sure that if they do have cirrhosis, they're in the correct management and surveillance program for cirrhosis. So, patient, they're into their primary care. They were told they had a high FIB4 count. They came over to hepatology clinic. What do we do? So, as you guys are aware, when we do liver transplant evaluations, we draw an exorbitant amount of blood. We're looking at other things. We're making sure that they don't have any concomitant liver disease. So, we want to make sure there's not something else hiding, that if it's just purely MASH. You can consider a liver biopsy. So, when do we do liver biopsies? If, let's say, their FIB4 is elevated, but maybe their FibroScan isn't, or maybe you've got all your non-invasive tests are not matching up and not making it a clear-cut case of, yes, this patient has advanced fibrosis, or no, this patient doesn't. So that's where you want to consider to do a liver biopsy. So indeterminate, your testing that you've done already doesn't give you a clear-cut answer. If you're not sure, like, is there an element of DILI here? Is there something else going on that you really want to rule out, and you need that tissue to be able to decide? Or there's persistent enzyme elevation. The picture isn't quite clear. You just need a little bit more information. So you get your liver biopsy, and you can see different stages that your liver biopsy are. Pathologist will give us a staging of fibrosis from 0, which is normal, to stage 4, which is cirrhosis. So then based on that staging is when you kind of helps guide what you're going to do. So if they have very minimal fibrosis, stage 0 to 1, that's someone that you can kind of reassess in 2 to 3 years. You don't need to worry about them right away. You can kind of talk to them about weight loss and different tools to help prevent kind of MASH from developing into more fibrosis. Stage 2 to 3, this is something where you want to reassess. You want to keep those patients kind of on your radar, and you can consider some pharmacotherapy. So there's new drugs that are available that just got FDA approved, not just, but are on the market to kind of help reverse that fibrosis in patients with MASH. Then stage 4, that's when you have cirrhosis. So basically, sometimes even stage 3, we might even consider that person and put them in the cirrhosis kind of management pathway. So it's when you're worried about development of varices, liver cancer, ascites, things like that. So those are the patients that are in the hepatology clinic regularly. And then you can biopsy, like a biopsy is not needed to diagnose cirrhosis. It was historically the gold standard, but since we have so many other testing, we can. So if you suspect cirrhosis clinically, or they have an ELF score that's very high, you would just basically put them in that cirrhosis management pathway. So really, when we look at kind of MASH and it's global, it really is a global epidemic. It's not something that's unique to the United States. But you can see here, this is data from 2000 to 2019. And really, it kind of gives us an understanding of how widespread this is. And you can see, like I said, it's not just a problem in North America. It really is a global issue. So let me talk about it. So when we look at the data for Americans, we can see that there's quite a large number that have MASLD. So we said these are patients that are seen in the primary care. They don't have significant fibrosis. So they're kind of holding out, working on different avenues to help control their steatosis, making sure their blood sugars are controlled, making sure their lipids are controlled, kind of working on weight if that's an issue. And then you can see there's this cohort of those patients, so 15 to 20 million in the United States, that develop MASH. So that's that steatohepatitis. That's when we start to worry that things are progressing. And then you can see here, if you look, like 20 to 30% of those patients with MASH will develop fibrosis. So that could be anywhere between stage 1 to stage 3. And we do have to worry about patients who start developing fibrosis if they are going to develop liver cancer. Then you can see, so we've got 20% of those patients go over 3 years to fibrosis. and then another 20% in another 3 years can go to cirrhosis. So that's quite a lot. 1 to 2 million people is quite a lot of people. So we are looking and trying to sort out why those patients, why certain patients move forward. Is there things we can do along the way to kind of stop the progression? And then you can see, once you have cirrhosis, we've seen these patients in the clinic. Carol they can develop hepatocellular carcinoma, they can develop liver failure, even death. And then those are the patients, the cirrhotics are the ones that we do see in the liver transplant clinic and can progress to needing liver transplant. So it's really looking at this whole pathway and trying to find ways along where we could stop the progression of this fibrosis. So here we see this kind of talks a little bit more in detail about what we just talked about. So on the left-hand side, we see a nice normal liver. It's nice and pink. It's got smooth edges. It looks very smooth. Then we can see kind of the progression along from to MASLD, then to more fibrosis, to cirrhosis, and then to liver cancer. And when we look at this kind of graph, we look and we know that obesity, diabetes, alcohol use can kind of push people along this so they can really move forward and kind of progress. There's also certain genetic polymorphisms. So you can see on the left-hand side where you see like PN, PLA3. And those are kind of, we're looking at to see those patients who have those polymorphisms do also progress kind of more quickly along this pathway. And then we can't forget the gut microbiome. So we can see that that your gut microbiome can be altered by diet and even in alcohol, and certain that can change the bile acid and metabolic dysfunction. And then these alterations can also promote progression to cirrhosis and HCC in those patients that are susceptible. So it's really kind of not just one pathway, but there are different kind of factors that we've identified that can kind of give us a hint as to which patients are more at risk for progression. So really in 2023, AASLD, they came out with some new guidance. We know that people with MASH and F2 to F4 fibrosis, so those patients who have more fibrosis, are at higher risk for liver-related events and mortality. So we call those patients, in the paper, they call them at-risk MASH patients. So these are the patients that need to be watched. These are the patients that probably need to be seen by a GI or hepatologist. And then we can see that the rates of fibrosis progression, so those patients that move from F2 to F3 to F4 and hepatic decompensations, really depend on baseline disease severity, those genetic factors that we talked about, the individual themselves, different environmental conditions, and then if they have other comorbid diseases. So that can always affect the rates of fibrosis progression. And we can see that in patients with MASLD without advanced fibrosis, cardiovascular disease is probably the most common cause of mortality, which kind of makes sense, right? These are patients that have diabetes, they have high blood pressure, they're obese, they have high cholesterol. So cardiovascular disease, that makes sense that these patients are going to succumb to those. But what we do see is death from liver disease is more prominent in patients with advanced fibrosis. So those patients that we've identified that have advanced fibrosis, then they're going to see more, their liver disease is going to contribute to death. So we'll take a little step back and we'll look at one of our patients. So this is JP. He's a 55-year-old male who is referred to your clinic because he's got elevation in his liver function test. So you do a little H&P, you find out that he has some right upper quadrant discomfort. He's gained about 20 pounds over the last 5 years, and he's had mostly normal liver chemistries over the previous 5 years, but mild intermittent elevation. So right now you see his ALT is 45, which is elevated, AST is 50. He's got a normal alkaline phosphatase and a normal bilirubin. He is obese. He's got a BMI of 35. He's pre-diabetic, so he's got a hemoglobin A1C of 6.3 and hypertension. So we think about that. That's 1, 2, 3 kind of things we can tick off on our checklist. He has no family known history of liver disease. He has rare alcohol consumption, so we can assume that he doesn't, alcohol is not playing a large part in his liver disease. He works in IT. He's on lisinopril, so he's on antihypertensive medication. And then when we do our exam, we see that he's really carrying a lot of his weight right in the central region. So we know that also puts him at high risk. So when you think of, okay, this patient's come to your clinic, they were concerned about steatosis, you also have to look at kind of their medication profile. So there are some medications you can see here that are known to cause steatosis on biopsy. So amiodarone, methotrexate, tamoxifen. So some medications that are used a lot. So you always have to do a good medication history when you're evaluating patients, especially liver patients, making sure they're not taking any herbs or supplements, things like that. But really looking at their medication profile. Then also looking, there's also other diseases that can kind of add to steatosis. So hepatitis C, Wilson's disease, hemochromatosis, people who are on parenteral nutrition. There's inborn errors of metabolism. So that can be like, mostly we see that in pediatrics, like maple syrup urine disease. And then I'm going to mispronounce it, but albuterolproteinemia, which is basically a metabolic where you can't process lipids correctly. And then lysosomal acid deficiency. So really having a good history, making sure you are talking with your patient, you're understanding everything, and kind of have a good background so you've kind of ruled out other etiologies. And you can see here, so on our patient evaluation, we're going to get a pretty significant laboratory workup. So this again is just ruling out other causes of steatosis, other causes of liver disease. You don't want to label someone as MASH and then they have some other issue that we need to treat. So we look at all our hepatitis serologies, iron stores, AMA, a celiac panel, ANA, anti-Semitic muscle antibodies, a CBC, a CMP, and INR. You do want to rule out HIV and alpha-1. So that's a pretty significant laboratory evaluation, but it's important to make sure that get a full, you're doing due justice for your patient. And then you can see here the abdominal ultrasound. So again, we know that we have to identify steatosis either by imaging or biopsy. And you can see here, it might be a little bit hard to see on your screens, but when we see fat in the liver ultrasound, it looks very bright. So on the bottom, you can kind of see it's a little bit more brighter. But again, you might not be able to tell. So I think that's also something that's really important. Like we get a lot of ultrasounds in the hepatology practice, and you want to make sure that you have a radiologist that understands what they're looking for and can help you read it. And really, in theory, when you get imaging on ultrasound, it really only detects like pretty moderate steatosis. If you just have a little bit, it shouldn't really detect it, but you have to be careful. And then you have to be careful, like sometimes with steatosis, the radiologist can't quite read fibrosis, so they might overcall and say rule out cirrhosis or something because they're seeing so much steatosis in the liver. So we get back to our patient. So we get our ultrasound. This is our ultrasound report. So it talks about increasing in hepatic echogenicity. So that's that steatosis with regions of focal fat sparing, which we do see. The contour appears smooth, so that's somewhat important. Usually with the cirrhotic liver, you'll see very lumpy. It won't be very smooth. Spleen size is also very important. If you have a large spleen, that can be concerning for portal hypertension. So the impression matches, right? Hepatic steatosis, fat in the liver with no evidence of portal hypertension. So that's important because that portal hypertension would then kind of push you to a pathway of more advanced fibrosis. So then talking about a liver biopsy, again, we kind of talked about it. If our non-invasive markers, so we get a Fib4, we get a FibroScan, and it just doesn't make sense, things aren't adding up, then you want to get a biopsy. Some medications to get prior authorization also require a biopsy because they need to prove how much fibrosis someone has. And again, we want to rule out other liver disease. So you can see here, again, I'm not sure how clear it is on your side, but you can see on the top, isolated steatosis. So you see those they look like almost like fat droplets that you're dropping. That's basically fat. So that's the steatosis. So when we go to Path Conference and we look, that's what we can see. On the bottom, we see the hepatitis. So you can see that there's kind of ballooning hepatocytes, they call them, kind of right here where you see more. It's not quite clear, just see, like just clear like that, like a fat droplet. And then, so for our guy, we know he has steatic liver disease. We got a liver ultrasound. It's sad he's got steatosis in the liver. We know fits a metabolic criteria, right? We know he's got a BMI, elevated BMI. We know he's pre-diabetic, or his hemoglobin A1C was greater than 7.5. We know he's on antihypertensive medications. So we say yes, he did admit to minimal alcohol use, so we don't think he has an alcohol liver disease overlap. So we're going to call him MASLD right now. So really the questions that we have to answer when we see kind of patients that get referred to you is, does this patient have underlying steatohepatitis? So are they MASLD versus MASH? Do they have any fibrosis? Because remember, once we start to see fibrosis, that's where we have to worry about. We're going to develop advanced fibrosis, F3, F4, and then we've got to worry about HCC and all the complications that come with it. So really, when you see patients, you want to kind of have a systematic way that you're going to evaluate them and be able to kind of categorize them so that they have an understanding of where they sit and what their risk factors are, and then you have a better way to help manage them with their primary care. It's also important for kind of when you're evaluating, so our kidney transplant patients and they get, they have elevated LFTs. This is kind of the same way that we go through to kind of determine whether or not they have advanced fibrosis, if they're going to need a liver and a kidney. So I think we're at the end of our talk. I'm going to stop sharing, but then if there's any questions, I'll be happy to answer any. Otherwise, I'll just thank everybody for coming. I appreciate all your support.